Good morning or afternoon. I'm Henrietta Smith, and I'm the subject matter expert for the new outpatient procedure component. The objectives for today's presentation are to discuss the primary intent of the NHSN outpatient procedure component, also known as OPC, to describe the two OPC modules within the component, and finally, to identify key differences between OPC and the patient safety component, PSC, for surgical site infection surveillance, SSI. This is a fun fact. In 2016, 3.4 million fee-for-service Medicare beneficiaries were treated in an ASC. Let's start with a bit of background on ASCs. To start with, what is an ASC? The definition found in the Code of Federal Regulations cites ASCs, also ambulatory surgery centers, as any distinct entity that operates exclusively for the purpose of providing surgical services to patients not requiring hospitalization, and in which the expected duration of services does not exceed 24 hours following an admission to the ASC. The healthcare environment of ASCs is different from that of acute care hospitals. ASCs are often specialty specific, usually only performing one type of procedure, such as only orthopedic procedures or only GI procedures. This facility type may not have staff members that are exclusively assigned to information technology or infection control. These areas may have staff that have multiple responsibilities with priorities that compete for their time. ASCs may or may not be affiliated with the hospital, and more than likely, the patient's contact with the facility is short-term, lasting only the duration of the surgical procedure. In contrast to ASCs, HOPDs, also known as hospital outpatient departments, are defined by the Code of Federal Regulations as a location that provides outpatient hospital services, such as diagnostic or preventative services, to outpatients, and is licensed or approved as a hospital and meets the requirements for participation in Medicare as a hospital. This facility type is not included in OPC. Just to note, data for HOPDs will continue to be reported using the patient safety component. As ASCs participating in CMS's Ambulatory Surgical Center Quality Reporting Program, ASCQR, report on a number of quality measures. 4 of these measures, ASC 1 through ASC 4, are included in OPC. These are outcome measures that are reported via claims-based mechanism using CMS's quality data codes. Beginning with the 2014-2015 influenza season, ambulatory surgery centers were required to report ASC Quality Measure 8, which is Healthcare Personnel Influenza Vaccination, which is HCP. This is reported as summary data using NHSN Healthcare Personnel Safety Component. Currently, there are no CMS mandates for ASCs to report surgical site infections, SSIs. There are a few states with state-based mandates for ASCs to report SSIs. These reporting mandates are currently done using the NHSN Patient Safety Component SSI protocol, which was discussed during the SSI presentation. Other than the state-based mandates, SSI reporting is optional for ASCs. Now that's a bit of background on ASCs. Let's take a look at what we're doing to address some of the specific needs for surveillance in these facility types using OPC. We anticipate launching OPC later this year. The functionality is being developed within the application. The primary intent of OPC is to provide a reporting platform to meet the specific needs of ambulatory surgery centers. OPC is created to allow ASCs to report mandated as well as optional measures by using one reporting system, NHSN. It contains two modules, the same-day outcome measures and the surgical site infection measure. Just a quick comment on the prophylactic antibiotic timing measure, ASC5. This measure is not included in the module as it was discontinued by CMS. OPC replaces the use of patient safety component SSI protocol for SSI reporting for ASCs. Because OPC replaces the use of patient safety for ASCs, the question that may come to mind is, how will ASCs that are currently enrolled in NHSN as facility type AMSURG be impacted by OPC? And this is a great question. ASCs that are currently enrolled in the NHSN patient safety component, no action is required. These facilities are automatically enrolled in OPC. ASCs that are currently only enrolled in the NHSN healthcare personnel safety component and they elect to participate in OPC, they will need to add OPC as a component within their reporting, and they will also need to complete the annual facility survey for ASCs. Lastly, ASCs that are currently not participating in any of the NHSN components will need to complete the NHSN enrollment process as well as complete the setup process. This is another ASC fun fact. In 2016, the number of ASCs increased by 1.4% to 5,532. And most of these new ASCs that were developed in 2016 were for-profit facilities. Now, looking at the same-day outcome measure, we'll use the acronym SDOM. Before getting started with reviewing the same-day outcome measures, I'd like to introduce the key term, encounter. For the purpose of NHSN reporting, an encounter is defined as any patient visit to an outpatient location where upon entry into the facility, the patient completes the registration process. And some ASCs may refer to this as an admission into the facility. The same-day outcome measures are serious events and include patient burn, patient fall, wrong events, and direct transfer or admission to an ASC. These are listed in the resource manual that was actually distributed during the conference. To fully meet this measure, when following this module, all ASC patients are monitored for each individual measure. Monitoring for these measures start on admission and end at discharge, and does not require post-discharge surveillance. SDOM-1, patient burn, is defined as any unintended tissue injury caused by any of the 6 recognized mechanisms: scalds, contact, fire, chemical, electrical, or radiation. A couple of examples are things like warming devices or PrEP solutions or lasers. This measure is used to assess the number of encounters who experience a burn prior to discharge from the ASC. The numerator is the total number of ASC encounters that experience a burn prior to discharge from the ASC, and the denominator is all encounters for the ASC. The next same-day outcome measure, SDOM-2, patient fall. A fall is defined as a sudden, uncontrolled, unintended downward displacement of the body to the ground or other object. This excludes falls resulting from violent blows or other purposeful actions. This measure is used to assess the number of encounters who experience a fall within the ASC. The numerator is the total number of ASC encounters who experience a fall within the confines of an ASC, and the denominator is all encounters for the ASC. SDOM-3, wrong event. The general definition of a wrong event is the performance or occurrence of a procedure in a way that was not in accordance with the intended surgical procedure. Specifically, the procedure is performed on the wrong body site or wrong body part, wrong side of the body, the wrong patient, wrong procedure, and or the wrong implant. This measure is used to assess the number of encounters who experience a wrong site, side, patient, procedure, or implant event. Numerator is the total number of ASC encounters who experience one or more wrong events. The denominator is all encounters for the ASC. SDOM-4, all cause hospital transfer or admission. A hospital transfer or admission is any direct transfer or admission from an ASC to an acute care hospital. This includes direct transfer and admission to a hospital emergency room. This measure is used to assess the percentage of ASC encounters who are transferred or admitted to a hospital upon discharge from the ASC. The numerator is the total number of ASC encounters requiring a hospital transfer or a hospital admission upon discharge from the ASC. Denominator is all ASC encounters. This is the denominator form for SDOM. There is only one denominator for all of the SDOM measures, which is the total number of encounters for the month. This is the same-day outcome measures event form. There's one form to be completed for each patient experiencing a same-day outcome event. If the patient experiences more than one different type of same-day outcome event during the same encounter, all events are recorded on the same form. For example, if a patient experiences a fall and a burn during the same encounter, only one form is completed. If the patient experiences more than one of the same type of same-day outcome measure events during the same encounter, that event type is recorded only once for that encounter. For example, if a patient has two wrong events, a wrong implant on the wrong side, only one wrong event should be recorded. And I think it's needless to say that, but I'll say it anyway, if a patient does not experience any of the same-day outcome events, no form should be completed. Reporting the same-day outcome measures using NHSN will not satisfy the CMS Ambulatory Surgery Center Quality Reporting, the ASCQR program reporting mandate. So using NHSN to report these measures is entirely optional. So the elephant that's in the room is, why would an ASC want to use the SDOM module for reporting? And again, this is an excellent question. The module provides ASCs with an opportunity to analyze other payer data along with its Medicare data in one system. Looking at trends and being able to track patterns, I think, is very critical. It also enables ASCs to benchmark against nationally aggregated ASC data. Another fun fact for ASCs, the majority of ASCs that billed Medicare in 2016 specialized in a single clinical area, with gastroenterology and ophthalmology being the most common. Now we'll take a look at the OP-SSI module. Just to kind of put this in context, if the NHSN components were family members, OPC would be the newest member. And as you can see, there's the same-day outcome measures module and the outpatient surgical site infection module. As we begin to discuss our discussion regarding the OP-SSI module, I'd like to reiterate that OPC replaces the use of the patient safety SSI protocol for ASCs that are performing SSI surveillance using the NHSN application. ASCs that have been performing SSI surveillance using the patient safety protocol, their SSI data will be copied to OPC and will be available for their analysis. Just want to point out the analysis that we've performed on the patient safety ASC data are risk adjusted based on the variables that are included in OPC. And we'll explore these variables in a little bit more detail shortly. I'd like to just introduce another key term. This term is similar to the term that is used in patient safety. And this is the NHSN operative procedure. These are procedures that are included in the CPT, the current procedural terminology code list, that have been mapped to one of the NHSN operative procedure categories. And during the operation, at least one incision is made through the skin or mucous membrane. This includes the laparoscopic approach using a scope. The incision may be left open during the prior operative procedure. And it takes place in the operating room or an area that meets the OR standards. An ASC may choose to monitor any or all of the 30 NHSN operative procedure categories that are available to ASCs, or as otherwise specified by mandates and other reporting requirements. All procedures within the selected operative procedure category must be monitored for SSIs, and the numerator is all SSIs that are identified for the selected operative procedure category, and the denominator is the total number of procedures for that selected operative procedure category. The OP SSI criteria are similar to those found within the patient safety component, the SSI protocol. There is a general SSI criteria that will be used for infections related to all of the operative procedures except breast surgeries. And there is a breast surgery infection criteria that will be used only for breast surgery infections. Copies of each of these are included in the resource manual, again, that was distributed during the conference. Just like the patient safety SSI protocol, all procedures that are included in the NHSN OPC monthly reporting plan should be monitored for all three levels: superficial incisional, deep incisional, and organ space infections. The module includes the ambulatory breast procedure SSI outcome measure for ASCs, and we'll get into the details of this shortly. The module also includes fewer reporting fields than the patient safety SSI module. Procedures are assigned to one of the 30 NHSN operative procedure categories based on the CPT codes mapped to these categories. The surveillance period is either 30 or 90 days, depending on the procedure category. And you can see here in this list that that's outlined. An important aspect of the module is that the operative procedure code, the CPT code, is a required field within the application. And this is different than that of the patient safety SSI protocol, where entering the code is optional. Procedure details such as emergency, trauma, and wound closure are excluded. And you can see this is a comparison of the patient safety and the outpatient procedure component, which variables are included. The procedures that do not generate an ASA score are excluded and should not be reported within the OPC. Procedure details when reporting spinal fusion, such as spinal level and approach or technique, are not included. Also, what's excluded is the specific type of hip arthroplasty and knee arthroplasty, such as total, partial, or resurfacing, and primary versus revision are not included. The patient safety SSI reporting instructions that are not included in OPC, the site-specific reporting details from Chapter 17, the surveillance definition for specific infections of types of infections are not included in the reporting requirements. This means that infections that are identified as organ space SSIs are not identified at the site-specific level. Also, the determination of infection or abscess present at the time of surgery, PATOS, is not included. This is a copy of the denominator for procedure form. And this should be completed for each procedure performed within the procedure category that is being monitored. This is the numerator form, also known as the SSI event form. This form is completed for each SSI identified. Monitoring for SSI events require post-discharge surveillance, and the OPC requires that ASCs record the method of identifying and detecting the SSI as an active or passive process. An active surveillance process is a process in which the facility has an active plan for identifying infections. The plan may include some of the following: review of the patient's medical record, post-discharge surgeon surveys, post-discharge patient letters, post-discharge patient phone calls, patients returning to the outpatient facility for follow-up, and cooperative agreements within the healthcare community where that facility resides. A passive process is identification of the infection that is not initiated by the facility. The facility has taken no specific actions to identify the infection. And again, this is a passive process in which the patient and or family may contact the facility to report, the surgeon contacts the facility to report, or another facility contacts the ASC. This is the second page of the SSI event form, and here I've highlighted the detailed question regarding how the SSI was detected. One of the things that we have taken into consideration is that facilities may not have a process developed. So there is a post-discharge surveillance, because post-discharge surveillance is critical for identifying and detecting the SSI. We've included an OPC post-discharge surveillance toolkit as an appendix within the protocol. There's a copy that includes, within the toolkit, there is a cover letter that provides instructions to the surgeon and his office staff. There is a sample of surgeon's line list, and then the post-discharge worksheet for suspected SSIs. Another ASC fact: the first freestanding ambulatory surgery facility was called Surgery Center, and it opened in Phoenix, Arizona in February of 1970 by two physicians. Within that facility, there were 5 physicians that performed 5 procedures. 4 of those procedures actually required general anesthesia. Now that we've had an overview of the OPC module, I'd like to describe a little bit more detail about the breast procedure SSI outcome measure. The ambulatory breast procedure surgical site infection measure for ASCs was developed from work that was done by the ASC QC, which is the Quality Collaboration, and NHSN, and we began this work in 2013. This was a collaborative effort to address the unique aspects of ASCs and the less than ideal fit for the patient safety SSI protocol for SSI surveillance in ASCs. The significance of the ambulatory breast measure is that it is a milestone toward developing SSI criteria for patients in the ambulatory surgery center. It also is helping to shape the landscape of the SSI module within the OPC. Based on the ASC data that had been collected within NHSN, breast procedures were selected because these procedures were found to be the highest volume operative procedure with the highest risk of developing an SSI. The breast measure specifications were developed in conjunction with the ASCQC, while the field testing for the measure was done by the Colorado Department of Public Health and Environment. This collective effort resulted in the breast measure receiving endorsement from the National Quality Forum, NQF. The data collection requirements that were used during the field testing were based on the patient safety SSI protocol and the site-specific breast infection criterion. And separate from the breast measure development process, we performed analysis on the NHSN ASC breast SSI data. There was both risk adjustment and statistical summarization that was done on the data. The development of the breast measure was a very rigorous process that required testing and justification for credibility. The measure testing was demonstrated that the measure was acceptable. It was the acceptability of the measure. The testing found the measure to be reasonably valid and feasible for use in the ASC environment. And the validity testing demonstrated that the measure accurately identifies breast SSIs. And lastly, the predictive modeling identified patient age and ASA score as strong predictors for SSIs following breast procedures. The NQF, which is the National Quality Forum, I'd just like to kind of pause just a minute and just talk a little bit about that, because the endorsement of NQF was such a significant piece of the breast measure. NQF is a nonprofit, nonpartisan, membership-based organization. And the organization was created in 1999 as a coalition of public and private sector leaders whose goal is to promote healthcare quality and ensure patient protection through measurement and public reporting. NQF endorsed measures are considered the gold standard for healthcare measurement in the U.S. Measures are evaluated through input from expert committees that are comprised of various stakeholders, including patients, providers, and payers. They evaluate the measures for NQF endorsement. Federal and state governments, as well as private sector organizations, use NQF endorsed measures because of the rigorous and consensus process behind the measure's approval process. As mentioned earlier, there is a separate set of criteria for reporting breast SSIs. It is included in the appendix of the protocol, and you'll notice that there are all three levels of tissue infection that's identified: superficial, incisional, deep incisional, and organ space. A little bit about the analysis options. Initially, the analysis for OPC will be very basic and consist of descriptive analyses of numerator and denominator data. Line listings, frequency tables, and basic charts such as bar and pie charts will be available. More detailed analyses such as standardized infection ratios, the SIR, rates, and run charts will be available as data are collected over time. The SSI is a risk-adjusted summary statistical measure that is helpful for comparison. Again, analysis of the patient safety ASC data is available to those ASCs that have participated, but will not reflect the criteria within OPC. Looking at the benefits of using OPC, it includes measures that are NQF endorsed or have been endorsed in the past. OPC SSI protocol is specifically developed and tested for use within ASCs. There are fewer variables for reporting. And the SSI breast criteria was developed in collaboration with the ASCQ, QC. And that is important to note because it was not developed in isolation or without the input from ASCs. Additional benefits is that it enables ASCs to benchmark against nationally aggregated data. And current reporting using the CMS quality data codes focuses on Medicare patients. OPC is an opportunity to collect data in one system for all payer types. Another ASC fact, in 2016, there were nearly 16,500 ORs in ASCs. That's an average of 3 ORs per facility. We'll look at a couple of questions that may come to mind. They're termed here as potential questions. The first is, if an ASC enters quality measures SDOM1 through SDOM4 into NHSN, will it still be required to report these measures as ASC1 through ASC4 via CMS ASCQR reporting system? And the answer to that is yes, they will still be required to report, as the CMS ASCQR reporting requirements for quality measures ASC1 through ASC4 is not met when these data are entered into NHSN. ASCs are still required to report ASC1 through 4 through the CMS reporting system. Question 2, if a patient has more than one event, will the ASC be required to complete multiple individual event forms? A single form is required for one or more of the same-day outcome measures, and a separate form is required for each SSI event. And a couple of examples. A patient experiences a burn while in the ASC and subsequently develops an SSI. One same-day outcome measures form is required for the burn, and one SSI event form is required for the SSI event. Another example, a patient experiences a fall and a wrong event during an ASC encounter. Both the fall and the wrong event are included on one same-day outcome event form. Question 4, will training be available for OPC and NHSN? And the answer to that is training materials are being developed for OPC and NHSN. We anticipate short one-topic videos, which we call quick learns, self-paced computer-based training modules, quick reference guides, and webinars will be available. The future direction of OPC. Based on what we learned through analyzing OPC data, we will continue to refine the contents for the ASC setting. and we will continue to tailor the contents of OPC for the ASC environment. And now to just summarize, OPC is being finalized, and we anticipate it launching later this year. After the launch of OPC, the patient safety component will no longer be available for ASCs, and it will replace this component. So state-based mandates which require patient safety for reporting SSIs will be done through OPC. The outpatient procedure component includes 2 modules, same-day outcome measures and the surgical site infection measure. Using OPC to report is optional for the CMS mandated measures such as the same-day outcome measures. For reporting SSIs for state-based mandates, users should follow the reporting requirements of their state. Again, if patient safety was required for reporting SSIs, then this reporting will be done through OPC. Another fun fact, geographically, the largest concentration of ASCs is in Maryland, where there are 5 ASCs per 10,000 Medicare Part B beneficiaries, followed by Georgia and Idaho, which have 3 ASCs per 10,000 beneficiaries. And Vermont, West Virginia, Alabama, and the District of Columbia, they have the fewest ASCs per 10,000, and that's 0.5 ASCs per 10,000 beneficiaries. Here are the references, and if you have questions related to the content or anything related to the reporting for ASCs for OPC, don't hesitate to email us at nhsn@cdc.gov.